Hi dear students, my dear upcoming urologists and few urology residents also happily has taken this program, video lectures. For all of you, keep enjoying these videos. Later you also become a faculty and you all are most welcome to the concept. Teaching is a passion. When you learn, you start loving the teaching, and those teaching is going to be useful for our dear juniors. Okay. So today we are going to see about partial nephrectomy or nephron sparing surgery. How the extended radical mastectomy become a breast conservation surgery. Something like that. The radical nephrectomy now becoming as nephron sparing surgery. Wherever possible, try to do nephron sparing surgery. That is a dictum, especially in the familial cancer syndromes, because there is a chance for multiple tumors. Okay, multicentricity and bilaterality. So as much as possible, try to do a nephron sparing surgery is gold standard. Okay, and try to preserve the kidney, preventing the patient to go into the dialysis and need for a transplant. So the gold standard for small renal mass is partial nephrectomy, of course. Yeah. The three-dimensional CT or MRI are very useful when you want to look for the renal parenchyma and the location of the tumor and the relevance of the anatomical location of the hilar vessels, the renal artery. All those things you can get wonderfully with the three-dimensional CT scan. So remember, with that we can even three-dimensional CT scan or MRI, we can do even the nephrometry scoring, also called as renal score. We will discuss it later part of this lecture. And to remember the indication, the T1A tumor, or nephron sparing surgery is the standard of care, T1A tumor. Okay, and for localized RCC, I told you the nephron sparing surgery, try to make it NSS, nephron sparing surgery, wherever possible to save the nephrons. That is the idea behind the nephron sparing surgery. So nephron sparing surgery is indicated in bilateral renal cell carcinoma, RCC associated with the familial syndrome, RCC in a solitary kidney. If you remove the kidney, the patient will become anephric and dialysis dependent. So all these cases, try to plan for a nephron sparing surgery. And the extended indication, the T1A is the real indication. The T1B, the T1A is, we know, less than 4 centimeter, and T1B is between 4 to 7 centimeter. So the tumor T1B is also extended. And for patient who has central tumors which abutting or invading the calyceal system, this point you have to take home, my dear friends. The central tumors which are abutting or invading the collecting system, or the tumor which are direct in contact with the renal artery or renal vein on CT scan, all are indications. They are called central tumors and hilar tumors. Both central and hilar tumors can also be done laparoscopically. That is another important point. Okay, the laparoscopy is now taking the as much role as possible. Now the robotic is also there. Minimally invasive surgery is taking upper hand because of faster early convalescence. Okay, what are the contraindications then? So the nephron sparing surgery is contraindicated when there is a node is enlarged. When I told you more than or equal to 2 centimeter node or chance for harboring the malignancy, almost always when the nodes are enlarged. When there is IVC thrombus, yes, it is contraindicated. When the tumor is invading the adjacent organ, T4 lesions, it is contraindicated. And I told you the hilar tumors, which is the central tumors which is abutting or invading the collecting system. But if the central collecting system, take this point, my dear friends, if the central collecting system is invaded, you can't do a nephron sparing surgery. It is a contraindicated. And tumor encases, if this is a renal pedicle and the tumor encases the renal pedicle, obviously it will be very difficult to do nephron sparing surgery, and it is contraindicated. And remember, when there is a global nephrons, minimum 20 to 30% global nephrons should be there to do a nephron sparing surgery. When it goes less than 20% global nephrons, there is no point in doing the nephron sparing surgery. Even the nephron sparing surgery, it results in hyperfiltration injury. Please remember, my dear friend, when the less than 20% global nephron is there, it can produce hyperfiltration injury, proteinuria, focal segmental glomerulosclerosis. We will see this point in subsequent slide. So remember, always consolidate the point. Don't read the point here as a contraindication and reading in the hyperfiltration injury as more than 80% nephron loss is there, the hyperfiltration injury. Consolidate both together. When there is a tumor when the global nephron is less than 20%, there is no chance you can do a nephron sparing surgery. And cold ischemia time more than 45 minutes. When there is a more than 45 minutes of the cold ischemia time, better take an extracorporeal renal surgery rather than going for a nephron sparing surgery. All these things are important. In general, with the warm ischemia time of less than 30 minutes, most of the nephron sparing surgery either by open or laparoscopically can be done. How much time? Less than 30 minutes of the time. When more than 45 minutes, the cold ischemia time is necessary. What to be done, my dear friend? Extracorporeal renal surgery, also called as bench nephrectomy. So you keep the kidney in the bench and do a procedure. This is called as, you take the kidney and keep it in the bench. That is an extracorporeal, extra body renal surgery, and remove all tumors and go with the further procedure. So that is called as extracorporeal renal surgery. To assess the partial nephrectomy feasibility, there are a lot of scores, but the scores which is really important, which is given in a Campbell, is 3 scores. Number 1 is a renal score, number 2 is a Padua score, number 3 is a C score, C central index score, centrality index score, also called a C score. So renal score, Padua score and centrality index score. Okay, these are the 3 scores which we are going to discuss for the feasibility of nephron sparing surgery. The renal score can divide the risk status into high chance for a high, intermediate and low. So when the score is low, there is a high chance for a nephron sparing surgery. We'll see one by one. So in a nephron sparing surgery, it includes the renal score includes RENAL. R stands for radius, N stands for nearness to the hilum, A stands for anterior or posterior location of the tumor, and RENA. A stands for anterior or posterior location of the tumor, and N stands for nearness to the hilum. So nearness to the collecting system. N stands for nearness to the collecting system, and L stands for relative location in relation to the polar lines. So remember, my dear friend, renal score also called as nephrometric score. So remember, 2 times the question has been asked in the AIIMS. Nephrometric score. N stands for nearness to the collecting system and L stands for location in relation to the polar lines. We will see that. Okay, so this is a points with respect to the renal score, but it is not given in a Campbell. They are taken outside the Campbell. So you can remember some points. So they may ask in the AIIMS. So I have given in the content. I am not going to discuss more. And point which does not go, it carries 1 point, 2 point, 3 points, and the that is a location, anterior or posterior, it doesn't carries any point. Okay, the anterior or posterior does not carry any point. So other points carries 1, 2, 3, depends upon the tumor radius less than 4 to 7, more than 7 centimeter, and depends upon the nearness to the collecting system, less than 7, more than 7 millimeter, 4 to 7 millimeter, and less than 4 millimeter, which carries 3 points, and exophytic or endophytic, totally endophytic carries 3 points, and more than 50% exophytic carries 1 point, less than 50% of exophytic, carries 2 points. Okay. So the location to the polar lines. Okay, with respect to the location to the polar lines, remember, one is there are two polar lines. This is one polar line. This is another polar line. So if the tumor is totally outside to the polar line, suppose a tumor is here or tumor is here, they are outside to the polar line, they carries 1 point. Suppose the tumor which crosses the polar line, the tumor is here, which crosses the polar line like this, which carries 2 points. Suppose if a tumor is located between the polar line, carries 3 points. If a tumor which crosses more than 50% of the polar line, carries 3 points. If the tumor which goes, this is the axial renal line. If the tumor here which goes and touches the axial renal line, okay, that carries a 3 points. So this is all about the renal score. So it can be divided into low, intermediate and high. I told you high carries 10 to 12 points and low carries 4 to 6 points. Okay, so remember this, in between is other. But all this not being discussed in the Campbell, my dear friend. They may not ask. But this is one of the decision making area. Sometimes in AIIMS, Viva you may get. So better you can, as a completion, you can remember this point. The Padua score is preoperative assessment. It is a preoperative aspects and dimension used for anatomical classification of tumors. So preoperative aspects and dimension used for anatomical classification of the tumor, Padua score. And another one is C score or centrality index score, which is nothing but the ratio between tumor center and kidney center and tumor radius. Ratio between tumor center and kidney center and tumor radius, that is C score. Okay, so there are multiple renal scores. We can use multiple renal score for example in the patient with the bilateral tumor or multiple tumors which can occur in a familial syndromes. You can use a multiple scores. And remember, when there is a multiple score, remember the formula: low risk, intermediate risk, high risk. 1 into low risk, 2 into intermediate risk, 3 into high risk. Remember like that. This is also not given in a Campbell, my dear friends. And less than 6 is favorable for partial nephrectomy, and more than 6 is not favorable for partial nephrectomy. Okay, remember this, if at all, added point. Okay, what are the ways we can do a partial nephrectomy? What are the types we can do a partial nephrectomy? Partial nephrectomy we can do as a wedge resection. Partial nephrectomy we can do as a enucleation or a segmental resection, or I told you extracorporeal renal surgery. Take the kidney outside, keep it in the bench and remove the tumor as a bench nephrectomy, and that is auto transplant to the patient. So it is called as extracorporeal renal surgery. Always the MCQ here you can get is Gerota's fascia and perirenal fat is preserved. Remember, my dear friend, the Gerota's fascia and perirenal fat is preserved in a nephron sparing surgery. Okay, so in radical nephrectomy, the concept of taking a perifacial removal is the 25% of the chance there is a chance the patient can harbor the tumor cells. But here what is being given is, please preserve the Gerota's fascia and perirenal fat. This is what is the idea behind in a nephron sparing surgery. Please remember that. Okay, because I will come to the point in this concept. And remember, when you take the tumor is surrounded by a capsule. Okay, the tumor as such is surrounded by a capsule, and the concept is, majority of the time the capsule is not infiltrated. That is a concept behind doing a enucleation. You can enucleate the tumor because only 40 to 50% of the time the tumor can infiltrate the capsule. We know very well the clear cell carcinoma is well encapsulated tumor. We have seen this point in the initial discussion. The clear cell carcinoma is well encapsulated tumor, and most of the tumors are well encapsulated because clear cell is the most common tumor. Very rarely the collecting dead tumors or sarcomatoid tumors or medullary carcinomas are infiltrative. Okay, majority of the clear cell tumors are, in general, the majority of the RCC subtypes are well encapsulated. That's the reason you can preserve the perirenal fascia and renal fat, and the tumor is less than 4 cm is most preferable, and wherever possible try to do a nephron sparing surgery and try to save the nephrons is the idea behind the partial nephrectomy. So the nephron sparing surgery, I told you, the enucleation and the standard partial nephrectomy. What is the difference between enucleation and standard partial nephrectomy? When you see this slide, the first one is standard partial nephrectomy, and the second one is enucleation. So the yellow marginated one is a pseudo capsule. The yellow marginated one is a pseudo capsule. So what is the concept behind the enucleation? You enucleate the tumor around the pseudocapsule. You can enucleate the tumor around the pseudocapsule, especially when there are familial syndrome like Warney-Linda syndromes. Okay, you can do a enucleation. That's a concept. But in a wide local excision or standard partial nephrectomy, rather than wide local excision, the standard partial nephrectomy, in addition to this, is a yellow one is a pseudocapsule. In addition to the pseudocapsule, what you do, you remove the 1 to 2 millimeter. How much you remove? You remove 2 to 3 millimeter. 2 to 3 millimeter of the normal parenchyma is also removed. So there's a chance for nephron loss. See, for example, in a papillary carcinoma, it is very prone for multiplicity. In a single kidney, there will be 3 or 4 tumors can be there. Okay. So when you do a standard partial nephrectomy with the 2 to 3 millimeter margin, there's a chance for nephron loss. So in such case, you can do a enucleation and you can remove it nicely. Okay, remember that is the difference. So in a enucleation, you spare the nephrons. In standard partial nephrectomy, the nephrons are lost because you give a 2 to 3 millimeter margin. And when you do a resection, it is not always possible entire aspects to do a enucleation. Sometimes you do a standard resection. So based upon that, for example, in the superficial aspect, you do a standard resection, and in the deeper aspect, you do a enucleation. Accordingly, you label the surgical procedure so that pathologist also it will be useful where there is a chance for a positive margins. All those things will be useful. That's called as SIB, surface, intermediate region and base of the tumor. Surface of the tumor, I am doing suppose partial standard resection. Intermediate and basal region, I am doing a enucleation or enucleo resection. I apply both. That is called, then it is called as SIB. You term it is called as SIB as a part of the procedure. You label it accordingly because it will be very helpful when we subject the specimen for the pathologist, and will be very useful when you identify the margin status also. Okay, margin status, there are changes. We'll discuss about the margin status when compared to the 12th edition. So when compared to the 11th edition, when there is a positive margin, don't worry, here the concept is changing. How will you do? What is the technique behind the partial nephrectomy? Okay, there are, if possible, do a off clamp technique without clamping. For example, if the tumor is superficially located tumor or exophagic tumor, you no need to put a clamp. You just dissect and open the Gerota's fascia and operate directly. That's called as off clamp technique. Another one is called as parenchymal compression. You compress the parenchyma. So this is a kidney. Kidneys, you can compress the kidney. This is a tumor is here. I am compressing the kidney. I am excising the tumor here. That is called as parenchymal compression. That clamping is called as Kaufman clamp. What is called as Kaufman clamp? Parenchymal compression. I am compressing the kidney nicely, and the tumor here is removed with the help of the diathermy, or you do a standard resection with a sharp dissection. Standard resection is done with sharply, or enucleation you do with a blunt dissection. Whatever you do, then you label it, okay, and you mention in the specimen. So the small exophagic tumor can be done. Exophagic tumors or small tumors can be done by Kaufman clamp or parenchymal compression. If you do a vascular clamping, so if there is this is a kidney, and artery, renal artery is there, you do a clamping of the renal artery. So when you do a renal artery clamping, the for example, segmental renal artery clamping is done, or a renal artery clamping, entire renal artery clamping is done. You want to further, you want to delineate the avascular line, you can put a indigo carmine dye so that it can give a clarity how much, what are the location of the avascular line, and accordingly we can do a procedure. For example, this will be still more useful when you do a segmental clamping. But the problem when you do a segmental clamping is, or selective renal artery clamping is, the patient can, the procedure will be lengthy procedure, the bleeding can also come. So longer operative time, extensive dissection, so need for the transfusion because of the bleeding. Okay, and hypothermia. How to create hypothermia? Hypothermia prevents the cells to get into the anaerobicity, and that thereby it prevents the cell from going into the irreversible renal injury. So when you, how you do a hypothermia?